Let's pull it together so that. Yeah, here we go. Get a plate. Get a plate. Get a plate. Probably get started, huh?
Hi.
Are we?
Nice to meet you.
Josephy Center. Nice to meet you. Thank you for having us.
Oh, I'm looking forward to it.
Good, good. Why did you mention hockey?
Yeah. So what days are there?
November 3rd, 4th. On campus, November 3rd, 4th, and 5th.
Just 3rd and 4th.
3rd and 4th.
3rd and 4th. Okay.
On camp is a program that we
you who that, that's Cheryl Collins, who's the director here. And the other thing I'll mention is that the exhibit that's up was curated by Ellen Bishop. It's called Chronicles of Change. So the artwork, the paintings, the photographs somehow have to address change. We had a well-attended opening here with a climatologist or a climate person from the Nez Perce tribe. And then they brought in a climatologist from the state of Oregon, and she was down at Fish Trap, when was it, last week, and Cheryl and I and 5 other people were there for that. And she was terrific. But it's on the Fish Trap YouTube channel, so you can, just a really good analysis of climate change. It was very nice.
In Oregon.
In Oregon, yeah. And relating especially to Eastern Oregon. She had pulled up stats on Eastern Oregon. So that, come on in.
How are you?
I'm good.
Good, man. Sorry,
Yeah.
just
How you doing?
Yes, we're
Oh,
open.
you are, okay.
We're open and Dan's about to get a talk.
I'm gonna stand for
You probably know everything already, Sean.
No, you're a kid, keep moving it, sorry.
Well, it's a great pleasure to have Dan here, and I tell people, they can't believe it, I'm on a Zoom call with the class of 60 a couple times from Oceanside, California, a couple times a month, and I say, yeah, we have a new hospital here, and we can go in we walk into our clinics. We can make appointments, but we can also walk in. And I said, and one time, I went into the clinic with a bad earache and got Dr. Powers, and she looked around my ear, and I had this, really pounding headache there. And she said, wait a second. And she ran down the hall and got the dentist and brought it back. He said, yeah, you got an infection in that tooth down there. And I said, why didn't you guys figure out to practice together before this way? She said, I don't know why it took us this long. But anyway, so I think we've got a pretty terrific healthcare system here. And Larry Gaines was the longtime administrator of the hospital and put together a lot of this stuff that we benefit from now. But he retired, and after a significant search, and unfortunately Nick Powers is out of town.
Lundy, yeah.
No, Nick Powers. You might have been out of town. I'm out of town, probably. Anyway, Nick Lundy, I know, was really excited to hire Dan Grigg. Dan and his wife, Adrian. Andrea.
Close.
See that?
It's close.
God, I think after 80 you get by with all that stuff, but anyway, we're so like, they moved here from Burns, and had practiced in Heppner before that. Dan had administered a hospital there, but also had some experience with bigger hospitals in California and Salem. And so I think we're really lucky to have him step in to be our CEO of our hospital. So, Andrew, have that.
Thank you, Rich.
We are streaming this, and so it will also be available on our YouTube.
Yeah, so I'm going to have to use the microphone, but I don't want to stand behind the podium. But this way I can see Mrs. Christensen. Is it Christensen? No. Yeah. Your last name? Stewart. Okay. All right. Well, it's good to be here with you this morning. Just afternoon, a couple of introductions. This is my family. So to the left, you see my wife, Andrea, and I. Oops. And then I've got a daughter who has a husband and 3 kids. They live in Nebraska. Another daughter here with her husband and 3 kids. They live in Arizona. And then he's next. He's still single, about turning 28 this year, and he's in Utah, working for a solar company. And then this young couple here just moved to Texas to teach 4th grade math. And this young man is in Chicago, Illinois, He's in Jakarta, Indonesia. And then our youngest, Seth, is here with us in Wallowa County. Seth's working at Safeway. Just started working at Safeway not too long ago. So wonderful family. Unfortunately, they're spread all over the world. So we're hoping that it's beautiful enough here for them that they'll come and visit. It's a great place for them to come and see us. My journey has mostly been in the western U.S. Born in Boise, in elementary school, moved around a little bit in Ontario, Springfield, and then ended up in Wyoming for junior high and high school. And then went to Spain for a couple of years, and then went to college in Utah and in Arizona. And then ended up working 14 years in Fresno, California. Then we moved up to Salem, and we spent 8 years at Salem Hospital before going over to Heppner, and then down to Burns, and now the northeast corner of the state. So that's the journey that I've been on. So I want to just differentiate a little bit. There's different kinds of hospitals. There's big hospitals, there's small ones, and when you get to the smaller ones, a lot of it, there's two designations. There's critical access, and for a critical access hospital, it's 25 beds or less, and there's some geographic restrictions. And there's also something called a district hospital. And the hospital here in Enterprise is both a district hospital and a critical access hospital. District hospitals benefit from the tax base, and they're quasi-public institutions. And so our hospital is both a district hospital. We get about $1 million a year in tax base. And then critical access designation is a federal designation through Medicare, and that's kind of how we're paid. They're paid a little bit differently than the big hospitals. So when you look at the state of Oregon, there are 25 critical access hospitals in the state. And on the eastern side, the ones with the red circles, those are also district hospitals. So here in Enterprise, Heppner, John Day, Burns, and Lakeview are both critical access and district hospitals. And so the five of us hospitals have quite a bit in common. And we have been doing for several years now a monthly CEO call, where the CEOs get on the Zoom call and we just talk about what are the challenges, what's going well, what can we do better, what can we learn from each other. And so during my 8 years in Burns, I got to know Larry Davey pretty well as a CEO here in Enterprise, because we would be on a call every month. We would talk offline at times. And it was a great camaraderie. And we recently added the administrator from Madison Prineville, because he felt left out. He wanted to be part of that with us. But what was interesting is during all my years in Burns, I knew that Enterprise had a really, really good hospital. Larry would talk to us about some of the cool things that they were doing, how great his leadership team was, the awards that they were winning. And so the reputation of the hospital here far exceeds Wallowa County. It goes way beyond. And some of let's see if I can take the next slide there. So on our most recent call, which was just a few weeks ago, the John Day CEO, he said, "Dan, now that you're there, tell us the secret. You know, how did that hospital get to be such a good hospital?" He said, "You've been there a few weeks now. What have you seen?" And here was my answer. Well, actually, before I give you my answer, this is the reputation. So consistently, a top 100 and top 20 critical access hospital in the country. No travelers in nursing. So let me clarify that. Through the pandemic, we lost a lot of healthcare workers, and nurses became very hard to recruit and retain. In Burns, there were still half of the nursing staff are travel nurses. Here in Enterprise, they're all employed and live locally, which is pretty amazing. Financially strong. The hospital here is completely out of debt, which is unheard of for a small hospital with a newer building like we have here. Really strong leadership team, great community support. These just represent some of the awards that the hospital has won. And so this was my response to my colleague CEOs, is I think they used a lot of discipline here to get to the point where we're at. Really strong leadership team, exceptional care, good environment, making sure the frontline caregivers have the supplies and equipment that they need. It's progressive and strategic in their thinking. There's opportunities to grow and just great community support. So that's my initial perception of how this hospital here got to be such a good hospital that wins awards year after year. So one question is bigger always better? Are you going to get better care at a big hospital than you're going to get at a little hospital? And my belief is there's always that perception that bigger is better, but is that really true? And I want to, just a brief story. I went to junior high and high school in a town called Green River, Wyoming, right here in the southwest corner of Wyoming. This town called Rock Springs was 12 miles away and has a hospital in Rock Springs, no hospital in Green River. When I was in 8th grade, my mother became pregnant with my youngest brother, and she chose to drive to Ogden, Utah for all of her doctor appointments and planned on delivering there at the Ogden Hospital. So that's about a 3-hour drive compared to a 15-minute drive to Rock Springs. And I remember just wondering, why would she do that? I mean, why not use the hospital in Rock Springs? But she was just convinced that the care was so much better at the big hospital than what she would get at the small one. And when she did go into labor, she ended up having my brother on the side of the road in an ambulance on the way to Ogden, Utah. There's a border hospital here in the city called Evanston, and she's checked in at that hospital, and they said, you better take an ambulance. And as they were transporting her, they pulled over to the side of the road and never made it to the Ogden Hospital. And that story just has always stuck out with me when I think about the big hospitals versus the small ones. And I've had the opportunity to work in both big and small, as Rich mentioned. My first job was in this hospital here, St. Agnes Medical Center in Fresno, California. Hospitals are sized by the number of beds that they have. So again, 25 bed is the limit for the critical access. The hospital here in Fresno, when I went there, it was 350 beds, and by the time I left, it was about 450 beds. They'd added on. And I went there as the quality director and spent a lot of years there working with quality and patient safety and some other administrative roles, and got to learn really well what it takes to make a big hospital a good hospital, high quality, safe for the patients. Then I went to Salem Hospital, and I don't know if you've met Dr. Hadley in the back. He worked nearby as part of the Salem system in the Dallas Hospital, which is one of the smaller ones. But at Salem Hospital, I went there also as the director of quality and patient safety, and spent my first 6 years working with that hospital on quality initiatives and efforts. And again, I learned really well what it takes to have good doctors and good nurses and good processes and good systems. And even though humans make mistakes and there's human error, what you can do to keep that error from reaching a patient and turning into a harm. So there's lots of science and work that goes into that. So then as I got to the small hospital, so this is the hospital in Heppner. It was a whole different world from a big hospital to a small hospital. But what I learned really quickly is the people are just as amazing in the small hospitals as they are in the big ones. You may not have all the services that you have in a big hospital, but what a small hospital does, they can do just as well as a big hospital can do. And that's carried through to my time in Burns, which was here, and now here in Wallowa. To my knowledge, we don't have an open heart surgery program here. We don't have the cancer center. But yet, the doctors are really good about getting patients where they need to go when they need those services and keeping people here for the things that they can do really well. And so that's been just a really important part of my career progression, to see the quality in both the small hospitals and the big ones. And I would say all of the hospitals I've worked at have had good quality care. But the hospital here has gotten the awards and done really well with that. There's a lot of challenges right now for small hospitals. This is a slide that I recently saw. 147 hospitals have closed since 2010, 190 since 2005. Now, most of those have been in the eastern part of the United States, none in Oregon during that period, thank goodness. Although a little closer to home here, you might have heard about Baker City closing their maternity unit, which has caused quite a consternation for the community there. And then Lake Health, Lakeview, which is in southeastern Oregon, they're closing down their hospice and their assisted living facilities. So financially, it's challenging to keep these small hospitals strong and vibrant. But again, the hospital here completely out of debt. And I think a lot of that is that community support, because if you trust a hospital, you're going to use it. If you don't trust it, you're going to drive. And so these small hospitals have to be probably even better than the big ones to gain that trust in the community, so that the community feels confident using it and knowing that they're going to get good care. Okay, so back to the awards that Wallowa Memorial Hospital has won. There's something called the Critical Access Top 20 and Top 100. So this company, Chartist Group, they're the ones that crunch the data and do the awards. Now you probably can't see the small print on this slide very well, but all of these things are the metrics that go into that award generation. So market share, quality, outcomes, patient perspective, cost, charges, and finance. They say that there's 38 indicators that they gather data on all of these small hospitals to rate them. And so in order to be a top 20 hospital, top 100, you are probably in the 99th percentile of all the hospitals in the country. So that means you're better than 99% of the other hospitals, according to the metrics that company uses. So pretty cool that this hospital has actually reached that point so many times. Just a little bit of data from our hospital. HCAHPS is a patient satisfaction survey. So if you go to the hospital and you get a survey after you leave, it's probably going to have some questions from this HCAHPS survey. And so we compile those and we track them. On the far right, WMH is Wallowa Memorial Hospital. And then compared to a regional hospital that's got really good scores, if you rate the hospital a 9 or 10 on a scale to 10, 87% of our patients are giving us that score. 84% are recommending our hospital. 83% say that their rooms were clean. 85% say there's really good communication with their doctor. So pretty good scores. And then over here on the recommend response, 89%, 72, 93, 94. And that's 2020, 21, 22, 23. So consistently, high response rate from our community that uses the hospital, that they had a good experience and that they would recommend it to their friends. Now let me be really clear. That doesn't mean that this hospital here is perfect, because there's not a perfect one anywhere. And again, there's human work that goes into these, and you might have a less than satisfactory visit, but the good hospitals are going to work hard to overcome that and get better and better day in, day out. And so I don't know what your experiences have been, but the majority of patients that use the hospital here have had good positive experiences. There's also a survey for the clinics. It's called CGCAPS. And from the clinic standpoint, and I'm glad that Nick, if you've met Nick Powers, Nick's the CEO for Winding Waters. So we're fortunate in this county to have two clinic systems. The Winding Waters Clinic that's been here for quite a few years, and then the hospital also has clinics. So you got the two different clinic systems. So the one that the hospital has, these are some of their scores. So during Q4 of 2022, and then so every 3 months here, the staff was courteous and helpful, 94%, 93, 93, 95. And then over here, rating their provider or the doctor, really high scores also, 94, 95%. Said that their doctor was one of the best. And then on the ER side, the average time that you're in, if you go to the ER for a visit, these times are the average from the point you enter into the hospital to the point you leave. So your entire visit stay is averaging just over a couple of hours in our hospital down to 90 minutes in third quarter of 2023. The 911, we also have the ambulance for the county. Within these number of minutes, that's from the time the call comes to the time the ambulance rolls out the door. So averaging just under 5 minutes in 2020, down to under 3 minutes now in 2023. Okay, a little bit more about again, we use the term health district. So think of it like a school district, because there's an elected board that come from people that live in the county, and there is that tax base that helps support it. We have, under that umbrella of a district, is the hospital, the clinics, senior living, the ambulance, all of those things fall under that umbrella of the health district. 5-person board. Rich mentioned Nick Lundy. He's the chair of our board. And all 5 board members are elected on 4-year terms. And then we have 1.5% property tax levy, and we employ 230 people, so one of the larger employers here in the county. And you see our mission and our vision and our values. Mission to provide premier health care. Vision is to be a recognized leader in mission, quality, and fiscal strength. And then the values down here at the bottom. I mentioned there were 25 beds. There's something called swing beds or transitional care beds. And let me explain that briefly. If you've had a hospital stay and you need some more time to rehabilitate, you could go to a skilled nursing facility to rehabilitate, or you could go to a critical access hospital and get that extended care. And so what Medicare allows us to do is use acute beds, inpatient beds, and swing those to transitional care beds. And so we can have both patients in the hospital at the same time, someone that's there for an acute stay or someone that's there for a swing bed or transitional care. Our emergency department's 24/7. We have the ambulance service. We do OB. And we have a pretty good group of chaplains, actually, that come and visit patients in the hospital, which is really nice. Some of our outpatient services are listed up there. Full set of imaging. So when this hospital was built, it did not include an on-site MRI unit. So there's been the MRI trailer coming in for years here. That's going to change in the spring. We've purchased a new MRI that will be permanent stationary. There's going to be another building built around it, just on the outside of the outside entrance of the radiology department. And so they'll be right there close by. So we're now recruiting for MRI techs and getting geared up and ready for that. We do quite a bit of physical therapy, a really strong physical therapy group with occupational health, speech pathology. There's a pediatric program also for the therapy. 24/7 lab, general surgery we offer, as well as orthopedic surgery. Chemotherapy infusions, which is really nice for patients undergoing therapy to not have to drive 3 days a week down to La Grande or somewhere else to be able to get that service here. Cardiopulmonary stress tests, echoes, a dietary, and then some telemedicine. On the clinic side, we have 4 clinics. The one in Enterprise, which is connected with the hospital in Winding Waters there. We have the downtown clinic, and then the Joseph Clinic here, and then the new clinic in Wallowa. And I'm gonna preemptively answer your question and ask Nick to help too. I always get asked, how come there's 2 clinics in Wallowa? And of course, it predated me. I wasn't part of that decision. But I think it's pretty cool for Wallowa to have 2 clinics. In Nick's clinics there, they're opening a pharmacy coming up, and also have dental care that we don't have in ours. And then in our clinics, we have x-ray and we have physical therapy. So there's some complementary services. So I guess technically the primary care would compete in Wallowa, but we have the other complementary services that are great for the community to have access to. Nick, anything you want to comment on that?
I think, that mix is amazing, and it will really save folks in Wallowa from all the drives that they've had to do. Be able to access all that huge range of services, and then even for labs, like I know I was just in our clinic the other day, and I saw the
Yeah.
Really good partnership.
Okay, and then these are the providers that are employed with us at our hospital. We have 12 providers that are employed: orthopedic surgery, Dr. Smith, Dr. Rose, general surgeon, and then you can see the rest of the group there: Dodie Beck, LCSW, which is social worker, Dr. Sheehan, Dr. O'Malley, Dr. Anna Hebert, and Tracy, and Paul and Michael are mid-level providers as family nurse practitioners or PAs, and then Kristen Kane, Katie Weller's a nurse practitioner, and Kelsey Allen is also a physician. So that's our group. Again, Winding Waters has a separate group from these. So there's quite a few providers really in our county. And I can tell you these are exceptional providers from what I've seen early on in my couple months here already. Okay, these are some of the services that we do in our clinic: the primary care, obstetrics, osteopathic manipulations, the surgery clinic. There's health classes, care coordination. We also have a visiting nurse service, so we don't have official home health in the county, but those home visits are done from the clinics, with nurses going out from the clinics into the homes. Then there's chronic care, sports coverage, Botox, behavioral health. So that's some of the services. Now, if we look ahead, I don't know if any of us can look around the corner, but I'm pretty sure spring is coming really soon. Even though winter starts tomorrow, I think, and then spring's right after that. But none of us can really see around the corner that well. When we first moved to Burns, probably about 6 months after we moved there was something called the Malheur Refuge Takeover. I don't know if any of you guys remember hearing about that. And so as a newbie at that hospital, we had to be prepared for however this was going to end. We didn't know whether it was going to be a big shootout with a lot of people being brought to the hospital, but we had to constantly be prepared and ready for whatever was going to happen. The FBI actually provided us with 3 physicians, a surgeon, an anesthesiologist, and an ER doctor, just to have extra medical personnel there. And the night that it did end, there was a shooting on the road between Burns and John Day, where one individual was killed and one was injured. That injured patient came to our hospital. That night we were on lockdown and had probably 12 FBI agents in full combat gear carrying machine guns walking around the hospital. It was pretty surreal. So you really don't know what's around the corner. And then follow that up with COVID-19, which everybody experienced. You didn't have to be in Harney County to experience COVID. And so even though we have our plans and we know what we want to get done over the next few years, or strategies and all that, there's these disruptors that can kind of get in the way sometimes. But that shouldn't keep us from moving forward and still looking at opportunities, how we continue to grow and progress. So these are some of the opportunities that I see so far in the short time I've been here, and as we've talked with our leadership. I mentioned that we're getting the new MRI unit. That should be here by end of spring. Our physical therapy department is kind of crowded if you look at the gym. So one opportunity is how can we give them a bigger space so that they've got a better place to do their therapy. Growing our own employees. One of the biggest challenges right now in healthcare, and it far extends beyond our county, is it's a challenge to find good employees. And even our non-healthcare businesses, I think, are finding it's hard to find good employees. And so we think that the answer to that is growing our own. And the hospital, and I give Larry credit because it was under Larry's leadership, made the decision that for certain hard-to-find specialties, we're going to pay for all of their college and give them a monthly stipend while they go to college. So we've got about 5 or 6 people right now in nursing programs, lab, not lab, but there's a couple other programs where we're paying for their education, but they're from here, they want to come back and work here, this is their home, and we're finding that's the best way to go than spending years trying to find someone from the outside to come in. So it's expensive up front, but the return on that long term is huge. So growing our own employees, capitalizing on new technology like telemedicine, artificial intelligence is gaining popularity. and there's a lot of healthcare applications with that are around the corner. Housing for new staff. When we do bring people in from the outside, this is a challenging one. What housing there is pretty expensive. It's hard to find rentals. It's hard for people, especially in the entry-level positions, to be able to afford housing here right now. And so we're looking at what can we do to supplement, or how can we help even provide some temporary housing for those employees. And then we think there's an opportunity to attract new specialties into the community. Maybe not full-time living here, but even if they come for a couple of days a month and do clinic visits. We do have cardiology and I think urology that do clinic work at the Winding Waters clinics. We have also oncologists that come into town right now. I think we've had podiatry. I don't know if that's continuing. So we've had certain specialists coming into the community where the patients can access those. I think there's an opportunity to expand that and to grow that more. It's not easy to find doctors that can pull away from a couple of days a month from their current practices elsewhere, but when they do and they come here, it's a huge help for our community not to have to travel and drive however many hours, take a full day off work for a 20-minute appointment. And so that's something I think we'll be looking at more. And then leadership development, the stronger we can make our management group, the better we're going to be as an organization. So investing in them and in their leadership skills and helping them to learn and grow. All right, so that's a really busy slide, but it's meant to just show you that there's a lot of thought that's gone into how can we serve our community better, how can we create value with the people that we work with, how can we grow, how can we provide good service, good quality, be financially strong, and a lot of good dedicated people working towards all of those aims. All right, so that's pretty much what I prepared for you today. I'd love to answer questions if you have any. Yeah, Dr. Graham.
Are there any plans to have a hospice team in Wallowa County? I mean, there used to be one, but my understanding is we don't have a hospice team now. Is that?
I think that's correct. I haven't had any of those conversations in the 2 months I've been here. Nick, I don't know if you guys have on the Winding Water side.
No recent discussions around hospice. My understanding, when the hospital or healthcare district stopped providing hospice services, it was because the administrative burden was getting so high for such a small population that it didn't make sense. And home health or now visiting nurse services made much more sense fiscally, which is unsustainable to try to do hospice. So that's the last I've heard. My understanding is no one's tried to restart that conversation. We have great visiting nurses. At least, 4 total? Like we have a couple?
Yeah.
So we do
Yeah.
have a vigorous home health.
We have
Yeah.
a great visiting nurse program, right? So we have to say visiting nurse program.
You can't call it
What's the
home health.
difference?
You know the difference?
I'm sure it has to do with the way it's licensed as well as reimbursed. Yeah.
And then payment, absolutely. But
But we have nurses going into the homes.
yeah, most days.
Okay, that's a good question. I just haven't been here long enough to have that conversation yet. Yeah.
I'm very pleased to hear, having just gotten an MRI and had to wait for it, I'm very pleased to hear that you're adding on an MRI, and it sounds like I retired from a small healthcare system that was not a district. So I agree with you about some of the advantages of a small system. You're much more nimble, or you can be much more responsive. It sounds like you're building a separate building and a walkway, and that we did that in my system in California too, but we did it because the regulations to add an MRI onto the hospital meant you had to have much higher construction costs, much higher requirements, so we put a walkway out there. Is that what you're doing?
Yeah. Yeah, there's
Same reason?
that decision was made before I got here, but I'm sure that probably played into it. It would be a lot more to break into the walls because you have to have the lead-lined rooms and do a lot of work for that. So my guess is that's probably why.
Yeah, and in terms of 4 specialties. Is
Mhm.
there any that you are hearing particularly people want?
You know, that's a,
Turning into a conversation. And if you'll stand back from that a little bit, I'll adjust the mic so
Okay.
that if you have a distance from it, it'll pick up everyone.
so this house is far
So
enough?
you stand there, and stand back. All right. Continue.
Got it. At least you can hear me. They might not hear me on YouTube, but you guys can hear me.
No,
Well-
I think he's got it so that this will pick all of us.
Okay, good.
Okay.
Good. That's a question I've been asking as I've been meeting with a lot of new people. And I'm hearing things like, it'd be nice to have, an endocrinologist. It'd be nice to have ENT here more. It'd be nice to have dialysis. It'd be nice to have dermatology. It'd be nice. So there's a lot of a nice list. Some of those are really, really hard to get, and some of them might be more realistic to get to come here. The podiatrist that I heard was coming is not going to continue, so that's something we might want to pursue more. I think dermatology would be great if we could get that here. We're in an area where there's lots of outdoors, there's lots of ranchers that spend their whole lives outside, and I think there'd be a great need for that. I think really anything that could keep people from having to drive as often, things that we would want to look at.
So my last question, and this is maybe for you too, Nick. We lost Renee Grandy, who was an alternative medicine doc here and did a lot of good for me and many other people. She was able to identify some issues that I think nobody else, that a typical MD would not have been able to diagnose. And so what are the plans to have, to replace that skill set that Dr. Grandy had here?
You want to start?
So I think Dr. Grandy's not replaceable, right? That's where I'll start. She's irreplaceable. And we are doing our best. So Dr. Annika Malley is really interested in a lot of the same aspects of care. So Dr. Malley's working really hard to gain knowledge in those realms, both by studying on her own and by continuing to consult with Dr. Grandy. So she's still, though not providing direct care with Winding Waters, she's still providing us advice. And then, we're kind of searching for what's next. How do we continue that legacy that is important?
I don't know, maybe Keith could say, but I think that dermatology, I can name several people here who have gone for skin cancer treatment to Lewiston or LeGrand or somewhere else. Did you get a lot of, you had kind of the same clientele in LeGrand as here. Was that a big issue?
Well, I think just getting in to see a dermatologist, even in Walla Walla, it's always been problematic. I mean, you try to call and get an appointment to have somebody seen, and it just was always difficult. That's an underserved specialty, I think.
Okay.
But a somewhat related question, and I don't really know how to phrase it. So I practiced in LeGrand for 25 years, and I knew the doctors here, but I always thought it was interesting that there seemed to be very little coordination between Grand Run Hospital and Wallowa Memorial Hospital, and I know there are probably a lot of reasons for that. That's not my question. But I noticed the referral patterns are very different. The doctors here tended to refer people to Spokane and Walla Walla. The LeGrand doctors, we tended to refer a lot of patients to Boise. It seemed like the referral patterns were different. A lot of people here didn't use the doctors in LeGrand. For example, I think they have 3 neurologists in LeGrand now. And I always thought it was odd that there weren't more referrals to LeGrand from Enterprise. Now, I saw patients from Enterprise in LeGrand, and there's certainly Pat McCarthy, the urologist, comes over here. So there is some, back and forth between the two hospitals. But I always thought there seemed to be a fairly significant lack of coordination between the two hospitals, and I could never really understand why that was. And I guess that's not really a question, but I suppose I would ask, is there an opportunity here for more coordination between the two hospitals?
I would think there'd be opportunity. The administrator down there, his name is Jeremy Davis. He's
Right.
been there a couple of years now. And I was at a meeting last week that Jeremy was at, and we talked afterwards about ER doctors. And is there an opportunity for the ER docs in LeGrand to be kind of in a call pool if we needed a day or two covered here and there? And because I had heard that they had a non-compete and couldn't come up here, but Jeremy clarified that that's not the case, and that if they're available, they could come up. So I think there's probably a lot of misconceptions that we can, as we spend time together, can overcome and work more closely together.
Yeah, I mean, I think these non-compete clauses have always been a real problem in my opinion, and I mean, that's been a real problem in the medical profession in general, when they write those into contracts and that doctors aren't allowed to, practice in a given area if they leave employment. And to me, that was restraint of trade, and I always refused to have it in my contracts. But I don't know if that's still a thing or not, now that I'm retired.
And maybe it's more the threat of it than the actual reality of it, I don't know. But I think there's opportunities for sure to work more closely. I can't speak for our doctors and their referring patterns and how those develop and could change, but at least from a hospital-to-hospital standpoint. Yeah.
I have another question. I've had this conversation with Dr. Malley, who is my primary care doctor. She's very interested in being able to use psilocybin for mental health conditions and for neurological conditions. And she has told me that it'll be at least a couple of years before she can get the training, but she's very interested in this. And I'm just wondering if you could put that on your list to think about for specialties. The research out there is getting better about how helpful psilocybin can be for mental health conditions, and I'd really like to have some place in northeastern Oregon where you can get that care under the right supervision, including microdosing as well as just full-out experience of being under psilocybin. So I recommend you take that under advisement.
Great. Thank you. Anything else?
My grandson happens to be sitting back there, and he's working in mental health now, but he's been riding along with the ambulance and is interested in getting EMT. And he said that the path to an EMT now is, am I right, Aiden, is online?
Yeah, Idaho.
Out of Idaho. Well, in years past, there used to be EMT classes here. And we trained up our own ambulance crews and stuff, right?
Yeah.
Was that too long ago? Am I too old?
No, we did that in Burns as well.
Did you? Well, it would just seem to me that, what, Angie?
Well, I know when we moved over here permanently was the year that it was changed to not being basically a volunteer.
Oh,
Because I was going to volunteer and went back to EMT school and got over here, and voila, it was no longer a volunteer situation. It was a paid, and I wouldn't have taken a paid position. So that was 2007.
you'd think that they could integrate volunteers along with paid staff.
But
It's super complicated because of liability is where I would go with that answer. Sorry, I'm not trying to crash your party, but when we think about how, like having a volunteer come and help out, I'm like, oh, Dr. Graham, you want to come help out once in a while, but not get paid, you know? It gets crazy complicated.
Well, anyway, it just, I don't know what, I forget who, Bruce Womack used to teach it, I forget who taught
Yeah,
the EMT classes here.
well, you have to do refresher courses anyway in hospitals.
I think that goes back to your point about grow your own, right? I think we're all trying to figure out how to make sure
Yeah.
the next crop of people is here to do the work.
Yeah.
Because it's
Can't figure out what to plan.
hard.
Yeah, if you do need, if you need EMT staff, recruiting them from somewhere else, the pay isn't probably good enough there to spend $400,000 for a house in Joseph.
Yeah. You know what's amazing? There are dozens of professions in a hospital. And I think if our kids in high school really realized all the different routes they could go, or even adults looking for a second career, I mean, there's really a lot of opportunity in healthcare.
So
Sounds like a job here.
what's the longest term planning going on in that hospital development? I mean, I don't expect looking at 100 years in the future, but that's not unreasonable. What's the position of the hospital admin in looking at the future of the hospital 10 years, 50 years, 100 years from now?
That's a really good question. Things change so fast, it's hard to predict what's going to happen in 100 years. I'd say where most of the work around that is on disaster planning and preparedness. That's where I hear the most talk about longer term. You know, making sure that you've got, you know, the supply of fuel and your generators are going to work for a certain number of days if there was an earthquake and that kind of thing. Also looking at the longevity of the plant. You know, when does the building need to be replaced again? You know, how long can you go with the current, you know, fixing things versus replacing? So a lot of the longer term planning is around those areas, at least from what I've been involved with. Because much of the services that we provide are population based. We got 7,500 people in our county that can only support so many services. If the county were to grow dramatically, then that would change what we're planning for as well.
So like with the idea of finding housing for new staff, is that let's find a hotel room for a week every week, or is that hospital buying real estate and building housing complexes?
More the latter. We already have, and Nick's part of this too, we already have temporary housing, you know, for travelers that come in or locum tenens doctors that come in. So we have places already for that. It's the people moving here and not being able to afford to buy something. What we're looking at is do we buy or build and give them 6 months to a year to live there while they find something? Or do we build something even more extensive that we then become their tenants, or they rent from us longer term? So I mean, those are all the discussions happening about housing, looking at all the different options. But like I will say, it's not real enticing to be a landlord. We don't want to do that, but also we might need to because it's the right thing to do, to find people.
Yeah. School districts are building houses.
Also, it doesn't, as far as planning ahead, doesn't the political climate kind of play into that? Because it seems like we've talked a lot about how this or that thing is happening, it's putting pressure on hospitals as far as, you know, different laws or whatever. The direction our healthcare system takes in this country could really completely change the...
Yeah, if the United States went to universal, or even if the state of Oregon went to universal health care, that dramatically changes the way we look at things too. Because of the payment systems that drive a lot of the services that are offered.
Yeah, like what can we afford to sustain, right? It's not about making a profit. Like Winding Water is a nonprofit, hospitals, a healthcare district. It's what can we afford to sustain depends very much on where that decimal point falls for whatever service.
Yeah.
So it feels scary to try to plan more than a couple of years out because you might make a decision that 3 years from now the rules change and you go,
Same thing in utilization, where the decimal point falls, depends whether you get the service or you don't.
Yeah.
That's hard.
Yeah.
You know, there are some services though that we're committed to providing even if they don't pay for themselves. OB is one of those.
Yeah.
We don't make a lot of money on OB, but that's a vital service that we're committed to. You know, just like the story of my mother, to have to drive when you're in labor is not the safest thing in the world. Yeah.
Just, well, are we in this county seeing a lot of having to use the Narcan or whatever it is for overdoses? I mean, you never see that, you know, it's not there used to be ambulance reports in the chieftain. You know, we used to see where the ambulance went. I mean, I know it's
Right.
medical.
I don't have an answer for how often it's used, but I know Nick's son, and Nick can speak to this, is working to make sure there's Narcan available with all the AEDs that are in the county.
Right.
Nick, I don't
And
know if
I'm
you want
just
to
curious
mention.
if
So
I've
what's the
heard
data
that, you
behind
know.
that?
Yeah, because,
I don't know off the top of my head. I think it's more, like the goal of that project is more a preventive measure, so that people get used to there being such a thing as a life-saving station. If it's an AED, it probably has some Narcan with it in case something happens. We're not seeing a huge groundswell, or I think we would like know some data off the tops of our heads. And it does happen, and so I'm sure there are ER visits for it. I'm sure there are folks in the community. I don't have the data like at my fingertips.
we were just in Sumter, and there was a little booth, get your free Narcan here.
Wow.
And so that just kind of, whoa.
It is a big push by the state of Oregon, and some of that, it's an important way to be able to respond in an emergency, but then it's also like a state like us to improve access to Narcan, to naloxone here. And so here's a way to say, hey, we're doing it kind of Wallowa County style. Please don't set up a booth on the side of the highway. Like we're gonna do it in a way that our community, thinks makes sense.
If I may
Yeah.
partially answer your question, I've been a firefighter here for Joseph for about a year and a half. And I've yet to administer or see somebody administer Narcan.
No.
I don't know
It's pretty
so
strange.
much
Yeah,
as
I
the
mean, that was when I
EMS.
first heard that they were, it's gonna go in the Methodist Church AED, it's like, oh, okay.
Yeah. Yeah,
It's
it's
prevalent, so prevalent that we need.
Well, it's
it.
going in all the AEDs.
Right, yeah.
Yeah,
It's just-
and all the ADs where people are comfortable with it, right? So it's not like
Right,
it has to happen. It's like we're reaching out to people
Yeah,
to say,
yeah.
what do you think? Can we do this?
yeah,
Um,
but that just kind of.
You know, back on population, you're talking about our population. I've been here 50 years. The population was about 7,000 when I got here, and it's been plus or minus 100 ever since until last year, and now it's jumped up to 7,500. So the population is growing a little bit, but more than that, I wonder, it seems to me that our tourist population is also growing significantly. So I wonder how much tourism plays into the healthcare system in terms of the visits you get, the ER work you get, the doctor visits,
And
is
that,
it significant?
from what I'm told, it does go up a lot in the summertime. So that would be attributed to the visitors.
Yeah. Do you see that?
Yeah, it's hundreds of people a year that we care for from outside the county.
Okay.
And from far away, right? So maybe last time I looked, it was about 400 people from zip codes that were far away, meaning, at least as far as Portland, and then much further, East Coast zip codes.
400, you said?
Yeah, so at our clinic, so not 10% of the patients we take care of, but getting up there.
Okay.
And then, there are a number of people that travel here because there's great healthcare. They travel here from a pretty big region regularly for their healthcare because it's better access here than they can get
that's
in
right.
Pendleton or in Baker or.
And probably part of the reason for the jump in the year-round population is the healthcare system.
Yeah.
I think that,
Definitely a chance to make a good impression at an ER visit. They go, wow, I just walked in, I got out of here in less than 90 minutes.
Hey,
maybe this is a place I could
Yeah,
live. That's an impressive statistic.
Yeah. Yeah, my class of 60 guys can't understand that you can see a doc within a week or two.
Yeah. If you text her, she probably wouldn't even mind. She'd go, hey, Rich, you know.
Ask them that safely. I'm sure they love that.
Maybe what we all do is tell all our friends and relatives to come up here and schedule their physicals.
Just nudge the revenue a little bit.
Yeah. Well, thank you very, very much, and good luck. I think you're off to a great start. And we had a small crowd, but I think we had an important crowd. You got to meet some, and I guess Dan was suggesting that he'd like to have a meeting of docs, of retired docs, who are maybe practiced here or maybe didn't practice here but are retired. So maybe this is a step that can get you going in that direction.
Thank you guys.
You're paying somebody $30 an hour to